Hello guys, today we are going to talk about the shock. The particularly the stage of shock. So let's begin. So we have three stages of shock. First is the compensated non-progressive initial reversible shock. The second is the progressive decompensated shock, and third is the irreversible decompensated shock. Now, in the first is so we have three stages of shock. First is the compensated, second is the progressive, and third is the irreversible decompensated shock. So coming to the first type of shock, that is the stage of shock. First is the compensated non-progressive initial reversible shock. So in the early stage of shock, an attempt is made to maintain adequate cerebral and coronary blood flow by redistribution of blood so that the vital organs, brain and heart are adequately perfused and oxygenated. Okay, so this is achieved by activation of various neurohormonal mechanisms causing widespread vasoconstriction and by fluid conservation by kidney. If the condition that caused the shock is adequately treated, the compensatory mechanism may be able to bring about recovery and re-establish the normal circulation. This is called compensated or reversible shock. This compensatory mechanism is under. Okay. So widespread vasoconstriction in the response to reduced blood flow, hypotension, and tissue anoxia. The neural and hormone the neural and humoral factors, example baroreceptors, chemoreceptors, catecholamines, renin, and angiotensin 2 are activated. All these bring about vasoconstriction, particularly in the vessels of the skin and abdominal viscera. Widespread vasoconstriction is a protective mechanism as it causes increased peripheral resistance, increased heart rate, tachycardia, and increased blood pressure. Okay. However, in septic shock, there is initial vasodilation followed by vasoconstriction. Okay. Besides, in severe septic shock, there is elevated level of thromboxane A2, which is a potent vasoconstrictor and may augment the cardiac output along with other sympathetic mechanisms. Clinically, cutaneous vasoconstriction is responsible for cool and pale skin in in initial, initial stage of shock. Okay. So in the compensatory mechanism, we have the first, that is the compensated or non-progressive initial or reversal shock. In this case, we can reverse the shock. We can reverse the shock. Okay. So there are various neurohormonal mechanisms which come under this compensatory mechanism. These are the renin, angiotensin, aldosterone mechanisms. Mm, then we have the baroreceptors. Then catecholamines, renin, and angiotensin 2 mechanism. So these all active and cause the decreasing and cause the vasoconstriction, particularly in the vessels of of the skin and abdominal vessel, so that the our brain and heart, they function normally. Okay. So widespread vasoconstriction is a protective mechanism, as it causes initial increased peripheral resistance, increased heart rate, tachycardia, and increased blood pressure. Okay. So in the case of septic shock, it is different. There is initial vasodilatation followed by vasoconstriction. Besides, in severe septic shock, there is elevated level of thromboxane A2. Okay, thromboxane A2 is increased in case of this septic shock, and It is a potent vasoconstrictor and can increase the cardiac output along with other sympathetic mechanisms. Okay. Clinically, cutaneous vasoconstriction is responsible for cool and pale skin in initial stage of shock. Okay. So fluid conservation by kidney. So this renin angiotensin aldosterone mechanism kicks in the action. So we have release of aldosterone from hypophysic kidney by activation of RAS system, release of ADH due to decreased effective circulating blood volume, and reduce GFR due to arteriolar constriction, shifting of tissue fluid into plasma due to lowered capillary hydrostatic hypotension. So, stimulation of adrenal medulla in response to low cardiac output adrenal medulla is stimulated to release excess of catecholamines, epinephrine and norepinephrine, which increases heart rate and try to increase cardiac output. Okay. So now we are coming to the second stage of shock, that is a progressive decompensated shock. So this is a stage when the patient suffers from some other stress or risk factors, example pre-existing cardiovascular and lung disease, besides persistence of the shock, so that there is progressive deterioration. The effects of progressive decompensation shock due to tissue hypoperfusion are as under. So, first is the pulmonary hypoperfusion. Decompensation shock worsens pulmonary perfusion and increases vascular permeability, resulting in tachypnea and adult respiratory distress syndrome (ARDS). Okay. So pulmonary hypoperfusion causes the decompensation shock pulmonary by pulmonary perfusion and increases the vascular permeability, resulting in tachypnea and adult respiratory distress syndrome (ARDS). Okay. So, uh, tissue ischemia, impaired tissue perfusion causes switch from aerobic to anaerobic glycolysis, resulting in the metabolic acidosis, lactic acidosis. Okay. Lactic acidosis lowers the tissue pH, which in turn makes the vasomotor response ineffective. This results in vasodilatation and peripheral pooling of blood. Okay. Clinically, at this stage, the patient develops confusion and worsening of the renal function. So, irreversible decompensated shock. When the shock is severe, progressive vasodilatation during later stage of shock, anoxia damages the capillary and venular wall, and arterioles become unresponsive to vasoconstrictor and begin to dilate. Vasodilatation results in peripheral pooling of blood, which further deteriorate the effective circulating blood volume. Increased vascular permeability, anoxic damage to tissues releases inflammatory mediators, which causes the increased vascular permeability. This results in escape of blood of fluid from circulation into the interstitial tissues, thus deteriorating effective cellular blood volume. So in a nutshell, the the story is like this. So first of all, shock happens. Shock happens due to various reasons. Causes are numerous causes are there of shock. So there is a decrease in blood volume. Blood volume decreases. Why? Because there is a vasodilatation because of histamine release and all other inflammatory mediators. Okay. So what do we have? We have hypertension. Hypertension means low BP. Okay. So to counteract this low BP, we have other mechanisms like RAS, catecholamine release, antidiuretic activation. So these are all the compensatory mechanisms which 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 try to prevent the hypertension by decreasing the by increasing the blood pressure. Okay, by increasing the blood pressure. Okay. So yeah, so okay, this part is clear. Okay, so then what happened that the that uh, due to progressive vasodilatation. Okay, so yeah, due to progressive vasodilatation, the anoxia damages the capillary wall and venular wall, and arterioles become unresponsive to vasodilator and begin to dilate. Okay, so this causes the accumulation of venous blood in the circulation. Okay, and this causes the decrease in the effective circulating blood volume. Okay, so and due to increased vascular permeability, the effective this also causes the decrease in effective circulating blood volume. Okay, so, and this can result in release of myocardial depression factor, progressive fall in blood pressure, and persistently reduced blood flow to myocardium causes coronary insufficiency and myocardial ischemia due to release of myocardial depression factor (MDF). This results in further depression of cardiac function, reduced cardiac output, and decreased blood flow. Okay, worsening pulmonary hypoperfusion. Further, pulmonary hypoperfusion causes respiratory distress due to pulmonary edema, tachypnea, and adult respiratory distress syndrome (ARDS). Anoxic damage to heart, kidney, and brain. Okay. Progressive tissue anoxia causes severe metabolic acidosis due to anaerobic glycolysis. Okay. There is a release of inflammatory cytokines and other inflammatory mediators and generation of free radicals. Since highly specialized cells of myocardium, proximal tubular cells of kidney, and neurons of CNS are dependent solely on the aerobic respiration of it for ATP generation. There is ischemic cell death in these tissues. So, so hypercoagulability of blood. Tissue damage in shock activates coagulation cascade with release of a clot promoting factor, thromboplastin, and release of a platelet aggregator (ADP), which contributes to slowing of bloodstream and vascular thrombosis. In this way, hypercoagulability of blood with consequent microthrombi impair the blood flow and cause further tissue necrosis. Clinically, at this stage, the patient has feature of a coma, worsened heart function, and progressive renal failure due to acute tubular necrosis. Okay. Hypoxic encephalopathy. If the blood pressure falls below 50 mmHg as occurring systemic hypertension in prolonged shock and cardiac arrest, brain suffers from serious ischemic damage with loss of cardiac function, coma, and vegetative state. Heart in shock. Heart is more vulnerable to effects of hypoxia than any other organ. Heart is affected in cardiogeny as well as in other forms of shock. There are two types of morphological changes in heart in all types of shock. Hemorrhage and necrosis. Okay. So there may be small or large ischemic areas or infarct, particularly localized in subapical and sub. Okay. So uh, subepicardial and subendocardial regions of the heart are very prone to the hemorrhage and necrosis. Okay. Shock lung. Lungs due to dual blood supply are generally not affected by hypovolemic shock, but in septic shock, the morphology changes in lungs are quite prominent term shock lung. Shock kidney. One of the important complications of shock is a irreversible renal injury. The renal ischemia following systemic hypertension is considered responsible for renal shock. for for renal changes in shock. The end result is generally anemia and death. Adrenals in shock. The adrenals show stress response in shock. This includes release of aldosterone in response to hypoxic kidney, release of glucocorticoids from adrenal cortex and catecholamines like adrenaline from adrenal medulla. In severe shock, acute adrenal hemorrhage necrosis may occur. Hemorrhagic gastroenteropathy. The hypoperfusion of the alimentary tract is in conditions like shock and cardiac failure may result in mucosal and mural infarction called hemorrhagic gastroenteropathy. This type of non-occlusive ischemic injury of bowel must be distinguished from full-fledged infarction, in which case the deeper less gut muscles and cirrhosis are also damaged. In shock due to burns, acute stress ulcers of stomach or duodenum may occur and are called as a curling ulcer. Curling ulcer. Okay. Liver in shock microscopically, depending upon the time lapse between injury and cell death, ischemic shrinkage, hydropic change, focal necrosis, and or change may be seen. Okay. Other organs like lymph nodes, spleen and pancreas may also show foci of necrosis in shock. Ischemia. So ischemia is defined as deficient blood supply to a part of tissue. So the cessation of blood supply may be complete ischemia or partial ischemia. The adverse severe effects of ischemia may result from three ways: hypoxic due to deprivation of tissue to of oxygen to tissues. This is the most important and common cause. It may be of four types. Hypoxia due to low oxygen in arterial blood. Anemic hypoxia due to low levels of hemoglobin in blood. Third is the stagnant hypoxia due to inadequate blood supply. And fourth is the histotoxic hypoxia, low oxygen uptake due to cellular toxicity. Malnutrition of cells due to inadequate supply of nutrients to the tissue. That is glucose, amino acid. This is less important. And inadequate clearance of metabolites, which results in accumulation of metabolic waste products in the affected tissue. This is relevant in some conditions like muscle ache after ischemia from heavy exercise. So, what are the causes of ischemia? What is the etiology of ischemia? A number of causes may produce ischemia. Causes in heart: inadequate cardiac output resulting from heart block, ventricular arrest, and fibrillation from various causes okay, may cause hypoxic injury to the brain. If RS continues for 15 seconds, consciousness is lost. If the condition lasts for more than 4 minutes, irreversible ischemic damage to brain occurs. If it is if it is prolonged for more than 8 minutes, death is inevitable. That is, death awaits and grave encounters. So causes in arteries. The commonest and most important causes of ischemia are due to obstruction in arterial blood supply. These are as under luminal occlusion of artery, thrombosis, and embolism. And causes in arterial wall vasospasm, example, Raynaud's disease, hypothermia, arteriosclerosis, polyarteritis nodosa, thromboangiitis obliterans, Buger's disease. Outside pressure on artery, ligature, tourniquet, tight plaster bandages, etc. Blockage of venous drainage may lead to engorgement and obstruction to arterial blood supply, resulting in ischemia. The examples include the following: luminal occlusion of vein, thrombosis of mesenteric veins, and cavernous sinus thrombosis. Second, causes in the vessel wall of vein, varicose veins of leg, and outside pressure of lung. Example is a strangulated hernia, intus, interception, and volvulus. So fourth is the causes in the microcirculation. Ischemia may result from occlusion of arteries, archipelagic veins. The causes are center luminal occlusion in microvasculature by examining the sickle cell anemia, red cell parasitized by malaria, acquired hemolytic anemia, sludging of blood by white cells, example in chronic myeloid leukemia, by fibrin, example defibrillation syndrome, and by fat embolism. Vasculitis, example polyarteritis nodosa, Hinox-Snolin purpura, arthritis reaction, and septicemia. Frostbite injury Frostbite injuring the wall of the small blood vessels. Example is the outside pressure on microvasculature. Effects of ischemia. So these are all the causes of the ischemia. Now we are talking about the effects of ischemia. So no effects on tissues if collagen channel develops adequately so that the effect of ischemia fails to occur. Second, functional disturbances. This result when collateral channels are able to supply blood during normal activity, but the supply is not adequate to withstand the effect of exhaustion. The examples are angina pectoris and intermittent claudication. Cellular change, partial and gradual ischemia may produce cellular changes. Okay, guys, that was it for pathology today. Bye bye.